Dear students, welcome to GAME. At the end of the class, I would like you people to kindly decipher the expansion of the mnemonic GAME. The class for today is gross. In the last class, we had seen the kidney, and now it is the large intestine. I have pertinently divided it into two parts, and this is part one of the large intestine. Anatomy. Anatomy is of paramount importance for the subjects of anatomy and surgery, and to some extent in pathology. The organ we are talking about, that is the colon, measures about 5 to 6 feet long. In meters, it is 1.5 meters. Whereas you find that the small intestine will be much longer. Development. Partly it develops from the midgut, that is the ascending and the transverse colon, and partly from the hindgut, the distal transverse and the sigmoid part of the colon, including the descending colon. So these are from the hindgut. The organs of the sigmoid and the rectum are intraperitoneum, whereas all the others that we had mentioned are retroperitoneum. By very strict definition, these parts, the cecum, appendix, and anorectum, are not involved in the colon. But for surgical pathology, it would be better that we include these for a complete examination and report. On my right, I am finding the parts of the colon, namely the ascending, the transverse, descending, and the sigmoid colon. And this is over here. I find that there is a larger and a wider loop over here, which is the large intestine, and there are multiple coils of the small intestine, all of which are delicately supported by the mesentery and its blood vessels. The points that we have to remember will be these: the haustra or the semilunar folds, which I will be showing you, or you will be seeing in all the specimens. Tinea coli, they are the strips of smooth muscle. Appendices epiploicae, or the tags of fat. The mesocolon, that is attached to the mesocolic region of the tinea coli and the omental coli. It is lined by simple columnar epithelium along with a good number of goblet cells. Crypts of labor cone can be seen. So this is the brief overlook of the anatomy and the histology. If you have got any doubt, you can please remember this mnemonic. Eva has 10 socks. Epiploic appendages, haustra are the circulations, tinea coli, and the semilunar folds. And that is exactly what we people are seeing over here. So appendices epiploicae, and then there are the tinea coli or the smooth muscle that will be leading on to the appendix, and haustra are the foldings. What are the types of surgeries that could be done on the colon? It can be a total colectomy, entire colon is removed, right hemicolectomy, which starts from the ileocecal valve, involves or includes the cecum, appendix, ascending colon, up to the hepatic flexure. Left hemicolectomy from the splenic flexure to the sigmoid colon. Transverse colectomy from the hepatic to the splenic flexures. And abdominal perineal resection, which will include the sigmoid, rectum, and the anus. So these are the types of resections that you people will have to remember. When it is going to be perineal, it will be sigmoid, rectum, and the anus. And this is a specimen of the right hemicolectomy, which could be identified by the ileocecal junction, the appendix, etc. And this is the mesenteric pad of fat or the omentric pad of fat. Certain organs or lesions, when they are given to you, are not of great difficulty to diagnose, but then it has to be orderly. Define, describe, denote, differentiate, or what are the differentials? Demarcate. Some mnemonic that I just designed. Definition. In one of the foremost colleges, when I asked the student, what is a gangrene? He was not able to answer. So such definitions you people will have to. I would advise you people to kindly go through my undergraduate classes for quick revision so that you do not waste much of time over that, and directly you can go in for the postgraduate portions. Colouterine fistula. Fistula again, there will be a definition. A fistula is supposed to be a narrow passage that connects two larger sacs or a large sac to the exterior. Such definitions you people should be knowing. I hope you can recall your surgery. In this case, it is a colouterine fistula that has been identified by means of a probe. On my right, it has got nothing to do with this. There is a lesion. I hope you will be able to identify it. There are some structures which we are teaching the undergraduate students. Definitely you people will know. But my question is, what are the differential diagnoses? How do you differentiate? Incidentally, this may or may not be kept as a specimen for you people, but it is definitely an important surgical specimen. The Hirschsprung's megacolon. Megacolon in the size, in the sense the size is increased, it is widened, and also you find that there is a narrowing and thickening at one end. So it is a typical picture of a Hirschsprung's colon, and I find that the tags of fat are creeping over the colon. In this, I am able to find contracted and thickened areas. Look at this area. Definitely there will be a hypertrophy and a contraction. So what happens is when there is an aganglionic segment, so this is definitely an aganglionic segment over here. Therefore, there is no peristalsis. But the body attempts to exclude the material by means of contraction. Since it fails, it becomes dilated. It is almost like a dilated cardiomyopathy. So it becomes dilated. It is not this region that is actually pathogenic, but this. So identify the distended area, and then you will have to look for the ganglion cells. Ganglion cells are large macrophage-like cells which have got a pale nuclei. And these are usually found between the folds of the muscle. The inner circular and the outer longitudinal muscles, between which you will be finding the ganglion cells. But the importance of a pathologist will be to find whether the segment is ganglionic, aganglionic, or even hypoganglionic. And we will have to report accordingly. Some people do give this as a frozen section, which my professor used to be against. Grossing is important, in which you will be able to identify these sections and report accordingly. In this one, there will be ganglion cells seen over here. I'm sorry, ganglion cells will not be seen over here, and this will be the ganglion rich area. There is a differential diagnosis which is called a Chagas megacolon. Here also I find that there is a distension. So obviously there will be an increased amount of peristalsis and absence over here. Therefore, the intervening colon becomes distended. Please understand these, and whenever you give a rare diagnosis, kindly be careful. We should not hit the raw nerve of an examiner. The blood supply. This is important for two reasons. Earlier, we had seen a specimen of gangrene. There is also something called as ischemic colitis. The blood supply will be these. There is a right, middle, and the left sigmoid arteries, and the innervation is given over here. The histology will be the columnar and the goblet cells and the crypts of Leiberkuhn. What are these? Ovoid spaces denoting. It is this. So I find that This is the colon. A better anatomy can be appreciated from this diagram itself. It bends upwards and there is a sigmoid colon, the rectum and the anal canal. The aorta, and there are the major branches. The major branches are encircled over here. There is a superior mesenteric artery. Whenever I use the word superior mesenteric, there will be an inferior mesenteric artery. Then there will be an internal iliac artery. There will be a middle rectal and an inferior rectal artery. Naturally, there will be a superior rectal artery. The other things you people may or may not remember. And there will be multiple small arteries, which are called the colic arteries, which are there and are seen as arches. One very good thing that we will have to appreciate from this picture is there is a very rich anastomosis. In the chapter on, or even in my class on infarct, I would have mentioned that this is one organ where there is a rich interarterial anastomosis, and hence there will be lesser chance of an infarct. However, there can be some areas called as watershed areas. Watershed areas are areas between two rich vascular supply. Here you find that there are two watershed areas. One is the splenic flexure and another one is the rectosigmoid region. These two are the watershed areas. Here I find that there will be an absence of blood supply in this particular region as well as here. So when there is a mild ischemia and the patient is anemic, this particular regions can go in for infarcts. These are called as watershed infarcts. They are called as Griffith's point and Sudek's point respectively. Diagnose and describe. Obviously, a specimen like this can be kept for you people, not directly, but it can form part of an autopsy, assembled autopsy. And naturally, we should know what a gangrene is. It is supposed to be a massive necrosis with superadded putrefaction. I find that it is distended. There is a blackish discoloration. There is a swelling or an edema that is over here, and a sense of shine will be seen, which we usually do not find in a dry infarct. And it is typically a wet infarct that will be there in a gangrene of the intestine. Volvulus can be one cause, or an intersusception can be another cause. Sometimes there can be a strangulation of a hernia. All these things you people can go back and read. This is it. So I find that there is an intersusception, a loop within a loop. This will commonly happen when there is one area which is aperistaltic and another area which is aggressively peristaltic. So one loop, the proximal will be going into the distal one, and it is called the intersusceptum, and this is the intersusceptions. Colonic diverticulosis. A diverticulum is nothing but a deviation, and it is blind. To give a good example, the appendix is a diverticulum. And you would have heard of the term Meckel's diverticulum and so on. This is a beautiful picture, and the source is this gentleman. None of the pictures here are my own. And I find that there are multiple ostia for the diverticulator. And externally, I will be able to see multiple foldings of this, which are actually the diverticulum. And there is a beautiful tags of fat that can be seen. So how do you say it is a large intestine? You people should be fluent. There is a large lumen. I can find the hostrations. There will be the increased mucosal folds. Diverticulum can be made out, tinea coli, so on and so forth. Again, the diverticulum. So I'll be able to make out the sac-like distensions on the external aspect. This, of course, is our friend, the tinea coli. And look at this. There's a mucosa that is bending down and it is going. I asked you earlier whether it is true or false. A true diverticulum will be having all the layers: mucosa, submucosa, muscularis, and the serosa. When it is going to be only the mucosa, it is called a false diverticulum. Ulcers. Again, definitions are my favorite questions. Ulcers are discontinuity of an intact lining epithelium caused by the gradual death of cells. You can get an ulcer anywhere. But let us limit ourselves to this one. I hope you people are able to identify it. Please think about it. We'll come to it. The ulcers may be superficial or they may be deep. They may be solitary. They may be multiple. They may be diffuse, or sometimes they can be accompanied with proliferation. So this is how you people qualify the ulcers. Again, they may be in etiology, infective, ischemic, inflammatory, or neoplastic. So these can be the various types and the causes of ulcers. This is the cecal region, and in this I am able to find one growth that is almost cauliflower-like, and since the cecum is quite large and capacious, the patient will not be having any feature of obstruction. We should not make a mistake of a malignancy. In fact, the endoscopist or even the surgeon will be in a hurry to diagnose it as a malignancy and do a hemicolectomy, finally to be diagnosed as tuberculosis. The differential diagnosis will be a serrated polyp. I have taken a detailed class of this in the recent advances. Please go back to it. It is an extremely difficult topic. Cancer of the cecum, an ulceroproliferative. It can be ulcerative, ulceroproliferative, or even purely proliferative. It can be a primary or a secondary lesion. And what are the other gross types of tuberculosis? Generally, tuberculosis, it can be ulcerative and it can be ulceroproliferative or hyperplastic. This indicates a good prognosis. This is another ulcer and we do not get it. It is caused by Clostridium difficile. I find that there is a superficial ulcer that is extensive and there is a greenish exudate. This is caused by Clostridium difficile, and this can be diagnosed by means of a colonoscope. This is a very good friend of ours. We will be knowing, we have read in our schools as well as undergraduation about the flask-shaped ulcers. So I find that there is a colonic mucosa, there is a narrow ulcer over here, and lower down I find that there is a widening of the lesion. Why it is like this, you people should explain. It is a typical flask-shaped ulcer of intestinal amoebiasis and have an eye for everything. Epithelium, submucosa. It does not go into the muscularis, etc. The reason is, and these are the trophozoites which you people see. The trophozoites are the active organisms and they may become somewhat pre-cystic and cystic. So in this one, there is the trophozoite. It is called as entamoeba histolyticum. Histolysis means obviously digestion, and entamoeba is because it is within the intestine. It is called histolyticum because it secretes an enzyme called histolysin. Therefore, it causes destruction. As it destroys the tissue, it cannot be surviving here. So it goes to the more viable region. That is why we get a flask-shaped ulcer developing in amoebiasis. And grossly, you will be finding a buttonhole. Look at this one. It's a classical picture. You find a button or a volcanic orifice-like structure. And they'll usually be multiple. I'm finding multiple shallow ulcers, diagnostic of amoebiasis. Have an eye for this. The eyes do not see what the mind does not know. This is a beautiful picture of the Crohn's, and the author is over here. I can see the creeping fat. There is a thickening of the wall. And in this picture, I'm able to find some skip lesions. This is showing the normal mucosa, whereas here, there is a cobblestone-like appearance. Obviously, there is a thickening of the wall and it is becoming rigid. We call it a lead pipe rigidity or a hose pipe-like rigidity. And you do an X-ray, a contrast X-ray, you will be finding a string sign. Again, the Crohn's disease continued thanks to web pathology. There will be the skip lesions, whereas in ulcerative colitis, it will be continuous lesion. Crohn's disease, it is supposed to be from the colon anywhere up to the oral cavity. And the lesions are skip lesions. You might get longitudinal ulcers, fissures, rather in a case of Crohn's disease. A cobblestone appearance. So look at this one. The mucosa is appearing like pebbles. A classical cobblestone appearance can be made out. Thickening of the wall that is seen in this as well as in the previous picture. A lead pipe rigidity, string sign, creeping fat, etc. Thanks to web pathology. So normally when you get a hemicolectomy or a colectomy or even a ileocolectomy specimen, you will be having some difficulty in opening it up. It is not so in an intestine normally, but here they are having some difficulty in opening up the intestine, and there is a thickening of the wall that is seen over here. The creeping fat also can be made out. And in this case, the typical cobblestone appearance can be made out, along with fissures. We'll go to the topic on polyps. A polyp is a lesion that projects above the surface. A polyp is a lesion that projects above the surface. It can be cutaneous, it can be mucosal, anywhere. And there is a term called a true polyp and a pseudo polyp. In this case, I find that the mucosa is virtually carpeted with polyps and we are not able to diagnose or see the normal mucosa at all. Obviously, the diagnosis has to be a familial polyposis. The definition of familial polyposis is when you find more than 100 polyps, it is supposed to be familial polyposis. And then when the malignancy is asked, it is 100% malignant or prone for malignancy. They will be asking you what are the syndromes associated with, therefore, the Gardner's syndrome, Turcot syndrome, and their components you people should be knowing. Polyp can be defined into a sessile polyp and a pedunculated polyp, or into a pseudo polyp and a true polyp, benign polyp and a malignant polyp. These are the ways that you people will have to do it. In one of my classes in recent advances on serrated lesions, I had mentioned this. Kindly go through it. The authors have done a wonderful work. Look at this, virtually carpeted, 100% prone for malignancy. Appendix. The positions of the appendix are more challenging to the surgeon than to the pathologist. Anatomical positions are given here. Kindly go through them. Appendicitis, we always give a diagnosis, acute, subacute, or chronic, just to defend our friend the surgeon. In many cases, it is not an inflammation at all. Gangrene, when there is going to be a blackish discoloration due to a limited amount of outflow, obstruction, stagnation, and then there can be development of a gangrene. Involvement of the mesoappendix is called the mesoappendicitis. Enterobius can be the parasite that can be found within the appendix, not uncommonly. Carcinoid is a tumor we should look for, mucosal of the appendix, mucinous tumor, etc. Sometimes we do get an adenocarcinoma also. So these are the various things we should be having in mind regarding the appendix. We are continuing with the morphology of the appendix. It is called vermiform because it is worm-like, and it is generally an appendage, a vestigial remnant that is there during development. The normal length is about 5 to 6 centimeters, though it can be as long as 9 centimeters, and rarely it can go up to 20 centimeters, it is said. In the appendix, we are supposed to give a cross section whenever we are doing a grossing, and also the longitudinal section towards the end, because that is an area prone for a carcinoid that has to be ruled out. In this case, it is too obvious, and therefore nobody will be making a mistake. Also look for multiple nodules like this. These can be tubercles, or there can be metastatic tumor deposits. So this, or an inflammatory exudate itself. This has to be studied and ruled out. So this we had already seen, a gangrenous appendicitis, and this can be a cause. Sometimes there can be a fecolith causing an obstruction. Whenever there is an obstruction, please remember, it is not the inflow of blood that matters, but the outflow. So there will be, the veins can be compressed quite easily. There will be no venous outflow. There is a stagnation. Whenever there is a stagnation, there is an increase in the flora leading to inflammation, and there is an appendicitis. This is the serosal exudate that can be seen. Externally, of course, there can be congestion in the mesoappendix. The tumors, it can be just a distension, which we can call a mucocele, or sometimes there can be a tumor within it. Therefore, in rare instances, there have been adenocarcinomata or even a mucinous adenocarcinoma that is possible. These will have to be ruled out, and sometimes it is only incidental that we do diagnose it. To be continued. In the next class, I shall be dealing with the neoplastic lesions.